Okay, so everyone from the COC side, Pad and Indaba, Kuhan, can you all hear me?
Yeah.
Yeah, absolutely. Hello, everyone.
Loud and clear. Hello, everyone.
Okay. So I think we'll get going. Apologies once again about the lack of video, apart from me. I'm not sure why that's happening, but if we can get it going during the webinar, we will do. So first of all, thank you to Jacob and John and Torben for helping us arrange this for all of you. It's a pleasure to be on here. And I've got on from the COC side a bunch of our doctors. So my role at the clinic is to help manage the operations with another colleague of mine, Yuri, who I believe has also joined. And then we have three of our doctors from the clinic on as well. We've got Dr. Mazabuko, Dr. Van Medeven, and Dr. Harry Harron, and Harry Harron as well. So I thought we would just start and give you an overview of the clinic. I'm sure you're all, or many of you are familiar with us. So some of this will not be new, but I will share my screen so we can run through this. So first of all, just to give you a bit of a background on Care Oncology Clinic, we were set up just over 5 years ago now. And the whole reason for the clinic's existence is to provide a type of treatment that isn't available elsewhere, and to do that in a safe and a structured manner. So we've now seen over the course of these few years over 3,000 patients. We've published our first journal paper, and we're continually working on both the treatment side and obviously the research side. The mission of the clinic is to deliver this treatment option immediately to help patients today, but also there's an aim of changing the wider cancer treatment landscape. Metabolic theory and metabolic therapy, which follows that, has really lagged behind the rest of oncology practice. And these are well understood existing drugs that we're dealing with, and we want them to be able to be used by clinicians much more widely, and we hope the data that we collect and report on will allow that. Some of you may know that the reason the clinic was set up, or one of the reasons the clinic was set up, was a very personal story. The wife of our co-founder, Robin Bannister, she had breast cancer, which became metastatic. And in thinking about additional options which may benefit her, he soon realized there was a wider application for this type of treatment, and set about working out how we could put this into practice and deliver a solution for all cancer patients. So going back again to this problem of unmet need, there's no other service really providing this in a structured fashion within a regulated setting. And we're bringing to bear the scientific expertise of Robin and his colleagues to really develop what we think is a very powerful combination in this space. Pad, do you want to talk a little bit about just the evolution of the protocol and these points here in terms of how we then brought it into being? Padman?
Yeah, I can kind of jump in with this if you like.
That's great. Thanks, Indaba.
Yeah, so I mean, essentially, there's been a lot of data, over several years with some agents, over a couple of decades even, looking at repurposed drugs in the cancer setting. So, in a way, this wasn't kind of a new discovery recently, but there hadn't really been a situation where all of that data had been sort of put into one place with the purpose of developing a bespoke therapeutic protocol for this. So what the clinic did several years ago was to then sort of do a systems review, essentially go through the data to try and collect a protocol that prioritized a few things. Obviously, it was very much about trying to get the data sets to be safe as a first point, but also to try and also make sure we maximize where the evidence base was. I'm sure a number of you will, be aware of a much wider cohort of drugs that are available in the setting, and I'm sure we can discuss a little bit about that later on. But what we wanted to make sure that we did was to actually get a protocol that was practical and manageable, so that people could daily sort of take, one that was safe, and one that actually could also be used in a research setting. So in other words, one that could get through ethics and MHRA, which is the sort of FDA equivalent in the UK, in order to collect data as we went as well. So that was quite important. So you may notice that our list of 4 or 5 drugs looks a lot shorter than some of the other lists you'll see out there, but it was important that we had something that we could study and document as we went. Yeah, I think that's it about the collection of the data. Was there anything else around that you wanted me to talk about, Raf?
Let me just move to the next slide if I can. 1 second. Yeah, if you're able to talk a little bit, just briefly, around some of the key mechanisms that these medicines target.
Yeah, absolutely. So as you can see there, there's the 4 drugs that we use on the protocol, and this has been standard for the life of the clinic since the beginning, really. And again, that in a way underscores the robustness of the initial systemic review that we did, because these drugs are still in current literature, gathering even more data and being validated in their use. So metformin is the first drug, and again, I know a lot of you know this before, but I'll very quickly run through it. Obviously, anti-diabetic drug, and there's a few very different mechanisms in terms of what it does. A lot of these are not new mechanisms. These are mechanisms that are used in other anti-cancer interventions. But of course, one of the key things that is great about metformin is safety profile, and that goes for the rest of the drugs as well. So it can target things like cell metabolism, growth, proliferation, etc., cell death, without causing a lot of the collateral damage that you will see with a lot of cytotoxic agents. And initially, a lot of people looked at metformin as an agent that was focused mainly on glycolysis pathways and the kind of the glucose metabolism stuff that we know is important in the anti-cancer setting. But actually, there is a number of things that have been added to the list of its actions, including inhibition of MMP, for example, cancer stem cell survival, immune system modulation, and that goes for a lot of the other drugs. So, all the statins, mebendazole, doxycycline, all have a longer list of things that they do. And an important aspect to how a lot of these metabolic drugs work is this synergy between drugs. So this idea that actually you have this situation where each drug on their own has a benefit, but actually the drugs in combination seem to have an effect that seems to be a larger effect than 1 + 1 equals 2. It's sort of 1 + 1 = 3, 4 or more in terms of the efficacy of these drugs. sometimes for reasons we're not quite clear on. But there does seem to be this kind of synergy effect that requires these drugs really to be in a protocol that is more than just the one age group. There are a number of studies you'll see on research.gov that looks at single agents. But the more we've been kind of at this, the more we recognize that actually there does need to be a combination to get the true benefit of that. And of course, on top of that, a lot of these drugs, their research comes out of combination with standard of care. So again, there does seem to be some synergy alongside that. So whether that's radiotherapy, for example, radiosensitization of these cells, or working alongside some of the cytotoxic chemotherapy. There's been a bit of data looking at using kind of low dose metronomic chemotherapy agents alongside metabolic agents. So there are various combinations, but the kind of take home message with a lot of this is that it does need to be a really comprehensive view of what you're doing. So not just targeting genetics, but looking at the metabolic processes, immunomodulatory processes as well, for example. So I think that's probably enough on that slide. Yeah, Rab, did you want to start on this, or do you want me to?
Yeah, I'll quickly just run through the summary of this, and then you can talk more about the match control analysis that we've recently done. So this was our first journal publication. It was published in Frontiers in Pharmacology in June of last year, and it's an analysis of our methodology in terms of tracing overall survival in our cohorts, with the example of the most aggressive brain tumor patient group, GBM. And we looked at 95 patients in that group. And what's on this slide here is a summary of the preliminary outcomes that we saw. So the key stats here really, or takeaways, are that the group as a whole, 95 patients, the median overall survival was 26.3 months and a 2-year survival of 55.8. And that's the whole cohort. Actually, the group of patients in our cohort who'd received the maximal standard of care, so surgery, chemotherapy, radiotherapy, median survival was actually even slightly higher, it was 27.1 months. And this compares, as you can see in the bottom bullet point, it's a really encouraging signal in terms of the improvement that these patients are getting over the median for standard of care treatment alone. And then what we've done now is move this analysis further on and done a matched control, which Ndaba will speak a little bit about.
Yeah, so this is just kind of building on, the great work that Dr. Pad and Raf and others kind of did in collecting that first cut of data. So, obviously one of the constructive criticisms of the first cut of data was the fact that it needed to be matched more closely with existing data in terms of much more specific matching. So, as Raf showed in the kind of in the sort of group analysis, it's very clear to show that there is an efficacy. But people quite rightly had questions about, well, are we clear that we are comparing like for like in terms of gender, in terms of age, in terms of intervention, for example. And so the next stage, which was done mostly by Dr. Steve Hagioff and co, was looking at kind of the banding of age and looking at trying to stratify that more closely. So with that group, we had 96, so very close, and we had the assistance of data from the National Registry that Public Health England very kindly made available for us. And then we looked at the mean and median survival. So in that cut of data, the statistically significant final analysis results was on the mean survival. And the comparison, again, was quite a remarkable shift, 700 days compared to 418 days with statistical significance there. So, that comes up to a 67% increase in the mean survival for those groups when you match very closely for the important stratification for that. And again, when you look longitudinally, it seems to hold up in terms of the 1-year survival at 81% versus 56% in the control group, and with the Public Health England data. So again, these are really quite remarkable results in this space, particularly when you look at the fact that, most of the people on the protocol, 85% plus, tolerated the protocol really well. One of the early sort of issues or fears about doing a study like this was that there were going to be issues with adverse events, so people not being able to tolerate the drugs very well. But actually, it's clear that, again, this is a strength of the way that the drugs were chosen in terms of their safety factor. But most people seem to be able to take these drugs alongside chemo. So most people were taking chemotherapy alongside this, or radiotherapy, etc., at some stage. But they tolerated them well, and the efficacy seems obviously very good alongside the quality of life. So I think that's really the take-home message is, they work alongside standard of care as a very good adjunct. And there's hard data about increase in survival time there. Great. Thanks, Raf.
Great. Thanks, Ndaba. Also wanted then to just provide a snapshot of the different types of disease that we've seen at the clinic, which I've summarized here on the following slides. These numbers are not 100% set in stone. They're an extract from our database, but they provide a pretty good guide as to all the different types of cancer that we've seen. And clearly the ones that commonly occur in the community, they're distributed in the same kind of fashion within our cohort at the clinic. So there's quite a number of patients with colorectal cancer, breast cancer of different types, and lung. And we have a very high number of brain patients, just because, sadly, in the aggressive variant of that, the prognosis is not so good. So the patients are motivated to seek out some other options there which may benefit them. So I'll just click through to show you some of the other numbers in different cohorts that we've got. Again, ovarian, quite a high number of patients, prostate. But we've really seen patients with disease across the board. And I think given the high degree of commonality in what has been shown to be metabolic alteration in cancer cells, irrespective of the tissue of origin, there's a rationale for seeking out a treatment like this, which is well tolerated. It's not designed to replace standard of care. There's less data in the context of some of the rarer cancers, but there's less data generally around all sorts of treatment options. That's just normally a reflection that not as much research has been done. But the mechanisms, going back to the slide Ndaba was talking through, the mechanisms that have been shown to be relevant are often the same ones. So again, it's regulation of glucose or cholesterol, or things like inhibiting matrix metalloproteinases, and these are relevant in a lot of different cancers. And then we wanted to talk a little bit about, before we move to the question and answer session, how we're currently able to work with patients in Denmark, and what our plan would be moving forward in an ideal world. So we are able to consult, as we do with many UK patients, in fact, via video. This would be after we have received documents from the patient, reviewed those to ensure that we think this is a suitable treatment option for that person to consider. And then we can consult, and that consultation follows exactly the same format as it does with patients in the UK. We're really talking about the patient's case. The doctor's trying to understand as much as they can about the history and the background and the current treatment options and any other health issues the patient may be dealing with in addition to their cancer. And then if appropriate, we can prescribe. And the way that we do that at the moment is via private prescription. And this can be taken to pharmacies in Denmark and filled under EU reciprocity. One new development, obviously, with Brexit is that there seems to be some confusion on the ground with pharmacies in Denmark who feel they may not be able to fill some of these prescriptions now. But I think with the transition arrangements that are running for the next year at least, nothing should change. And Jacob actually has some information from the health authorities in Denmark around that. And obviously, this is a way in which we can help patients right now. But we do have a very strong interest in developing a partnership with local doctors in Denmark, so that patients can have their consultations and appointments in their own language, and prescriptions can be written locally, and that will be a much smoother process ultimately. And of course, any new Danish operation that we set up will receive a lot of support from the UK and the whole team here. Indaba, have you got anything else that you would add onto that?
So in terms of just the logistics of working with the Danish population.
In terms of how that happens now, and then also our future plans. If you've got any additional comments, don't worry if I've covered everything.
Yeah, no, I don't think there's much that I have to add to that really. Yeah.
Okay, great. Thank you. So I'm sure a lot of you have questions, or some of you have questions. So please post them in the Q&A in the Zoom if you can, so we can get to those.
So there's a couple of questions in the Q&A.
Are you able to go in and answer those, Indaba? Are you able to pull up your Q&A box?
Yeah. So for the first question, I think there's one that's sort of been sort of handled separately. But so the first question that comes up here is from Dorte Hellbrink.
Yeah.
I hope I'm pronouncing that okay. So the first question is, do you have an experience with untreated breast cancer, intravenous vitamin C, and the drugs? Is how I'm reading that. So do feel free to correct me if I've misread that. But so I mean, essentially the broad answer to that question is we've seen a lot of patients. Raphael went through the numbers that we've seen with breast cancer. Obviously, one of the bigger groups that we have seen through the clinic, and at different stages. So a lot of people with kind of later stage disease, but increasingly people with early stage disease, and some people who haven't come in treated at that point. A lot of people that we see will opt separately to use intravenous vitamin C as well as other complementary agents. Obviously, that's not something that we directly do, but obviously we make sure we take a comprehensive history of everything else that people are doing. So, in short, the answer to that is yes. We have seen people with, all of those things with the medications. Obviously, our remit really is to focus on the repurposed drugs and the evidence base with that, and the efficacy linked to that. We obviously make a determination about safety with other things that are added in. So for us, it's important to make sure that we can comment on whether we think an additional vitamin or supplement is safe to be taken alongside these medications. But in terms of the efficacy of those other things, we tend to leave that to people who are directly using those agents to treat them. So the main thing I can say with that is that I don't have any issues in terms of safety for most people. Again, this is generalized. Obviously, individual cases might differ, but I don't have an obvious. There's no evidence to suggest there's any safety problems with intravenous vitamin C, for example, and the protocol. And we very, very much obviously keep an open approach to people adding in other things, as long as we can kind of be made aware in terms of double checking things like safety. But in terms of the efficacy, we tend to leave that to the people who will be prescribing those things. So I hope that answers your question. But if you have a follow-on from that, I'm very happy to answer that. I think there's a couple of other doctors on the call.
Yeah, I think I've now managed to.
So feel free to jump in with responses to this as well.
Yeah, I think I've managed to unmute Pad and Kuhan. So.
Sorry, Raf. Yeah, hello everyone. Sorry about earlier. I wasn't asleep. I was just muted. And Darbra, I think that was the same answer that I would give to Dortha for her question. The only thing that I just picked up on there with your question, Dorotha, is that you mentioned untreated breast cancer, and not to assume anything, but just from our point of view. I think at Care Oncology, we don't see ourselves as an alternative to standard medicines or standard of care therapies, as I'm sure you're all aware. We kind of see this metabolic treatment as a very adjunctive protocol, and the standard of care therapies that oncologists prescribe should always take priority. We very much see ourselves as an optimizing agent, and therefore the decision to have treatment with surgery, chemo, radiotherapy should always be made independently of the decision to start our protocol or not. Okay, so please don't go out there thinking that we replace the standard treatments, because there just isn't the sort of depth or the rigor of data to support that yet.
Thanks, Pad. Would you also, there's another question that's come in, a couple of questions on doxycycline. One regarding combination with immunotherapy.
Yeah. So I'll take that one, Raf.
Thanks, Kuhan.
So obviously when people talk about immunotherapy, it's kind of an umbrella term. It talks about lots of different types of drugs, but actually more than often people are talking about PD-1 or PD-L1 inhibitors like pembrolizumab or nivolumab or avelumab. And there are newer generation ones still. There were some recent publications a couple of months back which speculated, or spoke of the ability or potential for antibiotics to potentially be a negative or have a negative impact on the effects of immunotherapy. And on a very simplistic level, immunotherapy requires your immune cells, your lymphocytes, your T cells to work. But antibiotics can downregulate the number of immune cells you have in the body. And so what we sort of, after a discussion amongst the medics here and the doctors and so on and so forth, we decided to sort of err on the side of caution when it came to PD-1 and PD-L1 inhibitors. And so we actually now hold back off the doxycycline, and depending on the situation, we sort of consider escalating the dose of the mebendazole earlier than we may normally do, dependent on the tumor type. but it's something that we're also considering kind of continuing to monitor, because actually in the particular study we speak of, the antibiotics that were found to be sort of the most detriment were indeed more broad spectrum antibiotics like the penicillin based antibiotics, more so than the class of drugs doxycycline comes from. But certainly that is taken into account, and we do have many patients who are on the COC protocol alongside an immunotherapy, for example, for melanoma or lung cancer or some colorectal cancers, let alone kidney cancer and blood. Okay.
Pad, do you have anything to add to that?
No, I fully agree. I think that was a great answer.
Absolutely.
So, and I think the only thing about that study that Kuhn mentioned actually was a lot of assumptions are made about individual studies. So when there was a study that was published by some pretty fulminant professors of oncology in London, looking at patients who had had penicillins in the last 3 months and their lack of response to immunotherapy, that doesn't necessarily mean that it was caused by the antibiotics itself. It may have been a confounding issue where people were actually sicker if they had been receiving antibiotics, and therefore they were less likely to do well on the immunotherapy anyway. So it's not a definitive thing. I think it's just from our position as clinicians prescribing drugs with the sort of mantra of first doing no harm, we're always looking out for those issues to make sure that we are first and foremost being safe with our prescribing, which I think is what Kuhn was talking about.
Yeah. Thanks, Pat. There's a couple of related and very interesting questions from Lisa and from John about the medicines that we use and the specific medicines we use. So Lisa's question is, there are many, many off-label drugs which appear to have a positive effect on cancer, or at least there's some supporting or seemingly supporting data in the literature, and we use 4. Is more better? Does a patient benefit from taking more than 4 off-label drugs? So I wonder if you could just speak a little bit around our rationale and approach to that, Pad.
Yeah, I'm happy to. Ku, do you want to go for it, or?
No. Raf asked. Go for it, Pad.
Okay, fine. No, so it's a really good question, Lisa, and hello to you, by the way. And it's a really good question, and I think in the context of adjunctive therapies like we are prescribing, I think we thought when we first started this that 4 was a sort of sweet spot. And you have to think about what we're doing here is we are essentially a study. We are trying to compile a database of robust, rigorous scientific data, which we can then audit and hopefully publish and change prescribing practices around the globe if we find anything that is significant. Now, it'd be really difficult if we had a list of 30, 40, 50 drugs out there and we hypothesized on which drugs might be useful for which cancers. And there isn't very much data on that anyway. So we would be, almost adopting a trial and error sort of approach there. And at the end of it, we would probably come up with, we've treated around 3,000 patients. We'd probably have hundreds of combinations of drugs that all these patients were on. And therefore actually interrogating that data and trying to ascertain what is helpful and in which group of patients would be incredibly complex. We would have just nothing to show at the end of it. So one of the reasons that we chose these 4 drugs was because they satisfy 3 main criteria. Okay, number 1, they are incredibly safe. They're very non-toxic. We have never had a patient, as far as I'm aware, be admitted to hospital with a side effect directly caused by one of our drugs, which I think is an incredibly strong safety record. The evidence base for these 4 drugs is incredibly good as it can be, really. We're not just talking about a few studies in preclinical settings, test tubes or rats or mice. There are actually real life human studies and in some cases trials that support the use of these drugs in an anti-cancer setting. Okay, so safety, quality of data, and the third thing is complementarity of mechanisms, which is a really important one. We often find that when patients come to our clinic, they're taking 3, 4, 5 drugs and supplements sometimes, which all are hypothesized to work in very, very similar ways. So you're getting lots of clinical duplication without much benefit and the risk of more side effects, really. And from our point of view, we have lots of different types of patients which we have to cater for. some patients who are taking lots of drugs. They're on lots of chemotherapy drugs or immunotherapies or hormonal therapies, and then they're on, anti-sickness drugs and anti-diarrheal drugs and anti-nausea drugs. So there's an awful lot of tablet burden there already. If we're then prescribing patients, another 8, 10, 15 drugs, that's an awful lot for patients to go through, and actually quality of life can suffer quite extensively. So, we want to avoid polypharmacy. So we thought that 4 drugs was the sweet spot in terms of targeting as many different pathways that might be helpful in a metabolic setting, but not overloading the patients too much and causing too many side effects. So I hope that answers the question, Lisa. Feel free to chime in, Kuan.
Yeah, no, I just wanted to second that point. I mean, 100%, Padman. I mean, sometimes some physicians, we've come across them in the UK, or integrative doctors who do prescribe patients many different off-label drugs. But I'm always quite, I'm very skeptical about that, because actually, these are medicines that do have many side effects. You can talk about, whether it's propranolol or verapamil. These things are a beta blocker that can lower your blood pressure and lower your heart rate to the point where you faint. They have their problems that come with them, and so if you're taking 10 or 15 different off-label medicines, you are, greatly, putting yourself at risk for potential side effects. And as Pad, very correctly stated, that this being an adjunctive study, most of our patients being on a standard of care treatment, whether it's a chemotherapy or a radiotherapy or immunotherapy, the last thing you need to do is cause imbalance. And this is about an integrative, multi-pronged approach that has an equilibrium, whereby people can have the metabolic approach to sensitize their cancer cells whilst then having a direct cancer-killing effect. And so, it stands to reason, what number is enough? I think that is a question, obviously, that they sought to answer at the start of this study. And obviously the remit and one of the aspirations of Robin Bannister was for one day with our data set to be able to allow for our family doctors, our GPs, to be able to prescribe these medicines. And you can imagine some of the repurposed medicines, they're not, let alone not even available anymore. Maybe it's cimetidine or certain other drugs, or even hydroxychloroquine or dipyridamole. And so GPs and family doctors, let alone oncologists, would not be happy with prescribing them because of the potential side effects associated with them. But yeah, 100%, Pat. I think you completely covered everything now.
Thanks both. I wanted to say something on John Madsen's question about these 4 medicines and how they might work synergistically. That is something that obviously is an ongoing project, and I think the brain data that we've been able to report on so far is a strong indicator of likely synergies. There are studies that have been done elsewhere in glioblastoma just with mebendazole, and in America, for example, and the outcomes, I believe, that have been reported so far with mebendazole at much higher doses as a single adjunctive agent, potentially much more toxic at this higher dose as well. The results of that, or the initial results of that, are not quite as encouraging. So there are obviously many unknowns still in that scenario, but I think the data that we've reported builds on the mechanistic coherence you see around the way these drugs work, as reported in the research literature. Then there are also an increasing number of studies looking at metformin and statin together. And these could be trials, or they could be large cohorts, retrospective analyses of many thousands of patients. And we're seeing better outcomes in a number of different cancer types. I think prostate and endometrial recently, there was another report on where the combination of metformin and statin is producing much better results than what you would expect to see when patients are not on those 2 medications, or even if they're only on one of those drugs. The combination is showing much more encouraging results in the data. Is there anything on John's question, doctors, that you would add?
Yeah, it's a really good question, John. And just in terms of that word, synergy is an incredibly overused buzzword in scientific. Well, it's used all over the world in many different contexts, but it's something that is incredibly difficult to prove, actually. and synergy is more than just an additive effect. So what you're saying is when you add drug A onto drug B, the effect that you get is greater than the individual effects added together, if that makes sense. All right. And to even prove that in a clinical trial setting with a very tightly controlled group of patients and setting is almost impossible, really. So it's a little bit of a moot point, and actually lots of cancer agencies, charities, universities probably are quite frustrated because there are a lot of people out there making sort of claims about synergy without being able to robustly back them up. But it is almost impossible to back them up. What we can say is that using these 4 drugs at clinically relevant doses, but very safe doses, okay, seem to have an effect over and above just taking 1 or 2 of the drugs, but at much higher doses. And I think that's what Raf was alluding to when he talked about the ongoing study stroke trial at Johns Hopkins in the States. They're using incredibly high doses of mebendazole in glioblastoma. And unfortunately haven't really showed us much data yet because so many of the patients are having so much toxicity from those very high doses. Whereas our patients are tolerating the greater number of our patients are tolerating all 4 medications without overt side effects or overt changes to their quality of life. And it's impossible to untangle which of the drugs are affecting which of the patients. But actually, because we're not giving 4 or 5 chemotherapy agents here, we're giving 4 or 5 bog standard, boring, benign, safe drugs. We can do so safely. Okay, so this concept of synergism, I think, is a really difficult one. It's really difficult to prove outside of the clinical trial setting, but I think each of the drugs has shown that they're backed by sound evidence, sound safety data, and they have something to bring to the anti-cancer effect that we've demonstrated in GBM.
Yeah, and just to add on to Pad's point on that as well, very excellently summarized that whole section. But I think sometimes also there is a slight misunderstanding about the drug repurposing space as opposed to novel drug development, in the sense that that comment that John's mentioned about the agency saying we don't know which will work is something that obviously we've come up against here a few times as well. And I think sometimes when people think about drug research, it's always kind of in the model of the novel or the new agent, so something that's kind of being developed from scratch. And so in that sort of setting, absolutely, it would be very unusual to look at 4 new compounds or 4 new molecules in one space at the same time. But these drugs actually, because they're repurposed agents, already have this, the spectrum of data from an epidemiology point of view. And in fact, quite often they've come from that end where it's clear that A, they're safe, but A, they have an efficacy in patients, or an association with patients, with efficacy in patients, and then you sort of track back. So, the idea about, we don't know which will work is something that applies, more specifically to kind of novel agents, because you're trying to work out, do they work in the first place? But these agents already have data about some sort of epidemiological evidence base, and then you're working back to the lab data or the kind of preclinical animal data as well. So because they're safe and they often will be used together anyway outside of the cancer setting, it does become a bit of a moot point about which bit's working. We know the combination works, and we know that as an adjunct they work and it's safe, and that's the important bit.
Thanks, Ndaba. The next question is from Christina.
Should I take that one, Raf?
Sorry?
Should I take that, Raf?
Yes.
Right. So
just summarize the question briefly, and then if you want to take it.
Yeah.
So yes, this is a question about small cell cancer, spread to the kidney, and ongoing chemotherapy, but every third week. Cancer is stable currently. Would the COC protocol be an option in this setting? And the oncologist is unsure because of potential resistance to penicillin.
Okay, thank you, Christina, for your question. I hope your mum's well. It's a very good question. And actually, in my consultations, and I'm sure all of ours, often there is a little bit of tension or anxiety around the prescribing of an antibiotic on a regular basis. And as you know, we use doxycycline. I mean, the first thing to say, actually, I mean, the dose we use is half of a typical antibiotic dose for infections, and actually we use it often in a pulsed format, so a month on, a month off. Now, we've actually got real world experience with using doxycycline alongside chemotherapy in colorectal cancer. Often in bowel cancer, if you do not have what they call a KRAS mutation, patients are treated with a monoclonal antibody such as cetuximab or panitumumab, which causes a widespread acneiform rash all over the body and torso, and patients more often than not are treated with doxycycline for the entirety of their chemotherapy, which can often last 6 months. So again, that kind of idea, or the basic idea of this concern about antimicrobial resistance, is negated because it's something we've been doing in common practice, i.e. using specific doxycycline alongside chemo for quite some time in the mainstream. Of course, offhand, you hear about an antibiotic. The first thing most patients worry about of antimicrobial resistance, but beyond that, the affecting of the gut flora. And of course, as part of our regime, because we use treatments such as metformin, which can also cause tummy upset to some degree, we often advocate for the use of things such as probiotics. But rest assured, we have not seen any issue to indicate that there is a rising level of resistance to certainly penicillin, which isn't even an antibiotic that we use. I hope that answers that.
Pat, as we move down the list, would you like to just take the next one?
So is that from Jetta Christensen? Is that right?
Is there actually a question on that one?
When do I start the program?
That's the question for Jetta is right at the bottom, actually. I think she was having difficulty getting it to actually type into the box.
Operation.
So it's the second from the bottom.
Okay, hang on.
Third and second from the bottom.
Okay, right. So Jetta was diagnosed with triple-negative breast cancer in August 2018 and had neoadjuvant treatment and lumpectomy surgery in January 2019, followed by radiation. No lymph node involvement, but that has subsequently changed, and there is one lymph node involved. Tomorrow she'll be going through a lymphadenectomy. When do we suggest she should start the protocol? Okay. She believes that she's going to receive chemotherapy after this lymphadenectomy, and then possibly some radiation to the supraclavicular fossa and the axilla. Okay, so it's a very good question, Jetta, and thank you. And I wish you very well, first off, for the procedure tomorrow. I'm sure you're in very good hands. Okay. It's a good question, and I think that obviously the procedure that you're going through tomorrow is hopefully a short one. But in general, when we have patients who are going through surgery, we do tell them not to take our medications for probably 3 to 5 days beforehand, and for at least a week post-surgery. And the reason for that is that obviously when you have surgery, however small it might be, your body is obviously taking in a lot of new agents, whether that be anesthetics or new painkillers or anti-sickness medication. There's lots of possible drugs that might be prescribed in that setting, and it's always best, given what we're trying to do here, it's always best to try and make your body as in inverted commas clean as it can be during that surgical process. And so it's not an absolute rule. I often tell patients to stop their treatment for a week before and a week after. And we generally ask them to send us a copy of their discharge summary all the details of the surgical procedure, as well as the most recent blood test that they have, just so that we can make sure that, for example, their platelet count is okay, their white cell count and their hemoglobin is okay, and they haven't suffered any blood loss, to make sure that the liver function and the kidney function tests are all within acceptable limits. Just because, the last thing we would want to do is to put extra pressure on, you or any of the organ systems, which might have just been under a little bit more pressure during the surgical period. So for most patients, after a few days or at least a week post-surgery, everything is absolutely fine, depending on obviously the scale of the surgery. But there's no absolute rule. I think the best thing to do is just to let us know, send us the blood tests so that we can, use our expertise to review things and then get back to you with the right timings. But I wish you all the very best.
Thank you, sir.
Indaba, there's a question on breast cancer diagnosis in 2016 and ER positive, no NED today. Is the protocol suitable for someone like that?
Yeah, so that's the question from Stina Rom. Absolutely. So yeah, again, excellent question. This is something that is coming up quite a bit more recently at the clinic. Going back a little bit, when we started, this was mainly a protocol that we were administering people with kind of later stage disease, but more recently, thankfully, people have been finding out about us earlier, which is, I guess, part of it. But it's also clear in the evidence base, the literature, that actually there is a role for this type of metabolic approach in people who have no active cancer and essentially are using the protocol as a way to stave off or keep recurrence from happening. So yes, is the short answer to the question. Again, obviously, each case needs to be kind of considered individually, but we do have a number of patients now actually who are in your situation, Stina, with HER2 and estrogen receptor positive histories of cancer and are NED currently, and are essentially wanting to keep that away or keep healthy as long as possible. So yes, there is a flexibility built into the protocol to make allowance for individuals in terms of their particular situation. So it's not necessarily that every single individual will have to be on all 4 drugs forever. That is, what we take into account is quality of life, obviously. We take into account the kind of internal environment, which is why we do blood tests periodically, etc. So there is a flexibility about whether an individual would need to start 4 drugs at 35 and continue that, to age 100. So part of the monitoring process, which the clinic, puts a lot of time and effort into, is about working that out and understanding the individual patient in front of them and working with that. But the short answer is yes, there is certainly a place for the protocol in someone who is trying to look at keeping recurrence away.
Thanks, Indaba. Would one of the doctors like to take the question on the aggressive neuroendocrine cancer with metastases? Kuhan, would you like to talk about that one?
Sorry, I'm just trying to find the question.
From Helle.
That's right.
Yeah.
It's coming towards the bottom of the feed.
For Helle, okay. So hi Helle, Helle Johnson. So Helle's husband was diagnosed in 2018 with neuroendocrine primary tumor between the large intestine and the small intestine with liver metastases, spread to the breast lymph, key 67 and 65. So it's a small cell cancer, has had 6 rounds of carboplatin etoposide. Do you think that the COC probably would be an option for him? Well, yeah, so thank you again for your question, Hella. So I guess, you know, as you can probably tell from the various conversations we're having, we use our protocol for essentially most solid tissue, let alone blood cancers. And the aim there, or the remit there, is that essentially the mechanisms for metabolism in the cancer cells are pretty similar across the board. With an aggressive cancer like a neuroendocrine cancer, which emulates small cell lung cancers as well, which is why they use very similar chemotherapy regimes. Absolutely. I mean, the aim here is, again, to slow the progression of the cancer by harming the energy harnessing ability of the cancer cells. So, you know, whether we're using this on its own, as with the previous question answered by Ndaba, or if we're using this in combination with a mainstream strategy, whether it be a chemotherapy or not, then absolutely there's a merit in having a go at using the protocol. What it comes down to is, as to whether it would be an option for him, of course, is the basic things that we look for in each patient, you know, ensuring he's able to tolerate the medicines, you know, titrating the doses to him, his situation, his blood results. Of course, we're always aware, of course, in the context of chemotherapy, that there can be an imbalance in the blood tests, whether it's a full blood count, the kidney function, the liver function, and of course with the liver metastases, the whole point here, you know, if the liver function itself is okay, then, you know, we would argue that we could go ahead with certain doses of the various medicines with, of course, continued monitoring. But the aim of these treatments, the similar way to chemotherapy, to be systemic in nature, to work everywhere in the body. The primary tumor and the sites of metastasis, which are obvious in the scans, and those that aren't obvious in the scans as well. And of course, the combination strategy in using this, as we say, and we keep saying, as an adjunctive treatment, is a good one, because the aim here is to potentiate, to improve the efficacy and the outcome from that treatment itself.
Thanks, Kuhn. That's great. So I might just take a question towards the bottom from, excuse my pronunciation, but Hege Cecily, I think. This is regarding the atorvastatin and an increase in liver enzymes. And it really picks up from what Kuhn was saying about assessing each person and their specific case, you know, taking into account their baseline bloods, but not only the baseline bloods, if available, trends in blood tests over the preceding weeks and months. So we could see, you know, are there mild elevations? Are there sudden spikes? What are we seeing there? And also accounting for other treatment that may be running, you know, whether it's standard of care, chemo or immunotherapy or radio, or other medicines which are being taken for other health conditions. It's really a whole picture that needs to be taken into account, you know, when deciding whether somebody is a suitable candidate or whether we need to make some adjustments to the protocol to maximize the safety and the efficacy of the treatment. So then coming to this specific question about statin and an increase in liver enzymes, what we would do there is look at obviously what dose of the statin was being taken, how significant was the increase, was it incremental or was it sudden? Are there other things which may have contributed to this spike, whether it's standard treatment or possibly even a range of new supplements which could have been introduced and had an impact on the liver. So we would look at all of that, and if appropriate, we may trial a different statin. So the question was about whether simvastatin is another option. In some cases, we do consider that to be an option because it's in the same class as atorva. It's also a lipophilic statin, which means that the absorption of it where it's needed is better than hydrophilic statins. So we would look at that, and dose for dose, it's less potent, if you like. So we can prescribe that at a lower dose, see if that's better tolerated, monitor the blood test results, and then take further decisions from there. You know, we may keep the low dose Simva in place, or we might decide down the line, if things are changing and things continue to be stable, that we can retrial again at a higher dose to try to aim for maximum therapeutic effect.
Raf?
Yes.
There was a question higher up from a Berit Hugard for about 5:26 p.m. I don't know if we...
Let's have a look at that.
My wife suffers from diarrhea.
Yes. Do you want to talk about that one?
Oh, walked into that one, didn't I? Hi, Barrett. Barrett Hugard. Thank you for your question. I'm sorry to hear that, obviously, your wife has had such a difficult time, and I'm glad to hear she stopped. Notoriously, of course, metformin can cause tummy upset. It's not very common, but there can be a grumbling tummy issue, whether it's nausea, appetite disturbance, bloating, flatulence, diarrhea, abdominal pain. Extremely rare. Obviously I'm not sure of the ins and outs and what dose she was taking and what else she was taking or doing at the same time. But of course, I see that the decision was made to stop it. I mean, typically to try and ensure tolerability, we always advise, well, firstly, we prescribe metformin modified release, certainly in this country. And the aim there is to, again, reduce the gut toxicity. We also advise to take the metformin with or after a meal if possible. If the modified release preparation is an issue, we try a normal release preparation. And I guess, if you've tried all of these measures and there are problems, then of course the right thing to do is to stop, because 10 to 14 times a day is a very significant amount to run back and forth to the loo. I think, and those measures have been attempted, then, there isn't obviously much worth in trying to use the metformin. Obviously as part of our remit with the COC protocol, though we don't openly advocate for taking other things, patients, often do try and do their research, and they do try and run things by us more often than not. And one of the compounds that often does come up, though we don't officially say you should do this or that, is berberine. And I say this from actually the opposite point of view, because patients often come to us and they ask us about taking berberine, or they're already on berberine, which of course is a very interesting, very good natural supplement that does a lot of different things. However, unfortunately, there's often an overlap with the mechanism of action, the MAP kinase pathways, with metformin. So we often advocate for not doing both at the same time. But I've got many patients who have considered alternatives and they've gone and sought advice elsewhere. But I think, going through those motions, of course, if you wanted to contact us and ask us about or tell us a little bit more about the metformin situation, I'd be more than happy to try and help if I can.
Thanks, Kuhn. There's a question about itching and whether that can be normal. Is it okay? What might we do to try to determine, what could be causing the itching, and could this be related to the COC medicines?
Is that from Gitta Anderson? Is that right?
Yes.
Hello, Gitta, and I'm sorry your husband developed some itching. So it's not normal. Having, obviously any skin symptoms, it's not normal to have that. There are many causes for skin rashes or itching, or hives or anything like that. Some can be caused by drugs. Some can be caused by the disease itself. Some can be caused by things that are nothing to do with either, to be honest. In our role as obviously doctors prescribing sort of medicines for a slightly different license, for a slightly different condition than for what they're licensed, we obviously have to be a little bit more careful, a little bit more belts and braces to make sure that our drugs aren't causing any symptoms or harm or affecting people's quality of life. So, in this setting, what we would normally advise would be to stop our protocol and see what happens to the symptoms. Okay, and normally if it is a drug-induced symptom, such as an itch or a rash, then we should start to see some changes, within 2 or 3 days and see some amelioration. Okay, what I'm keen to avoid is for patients to be taking, drugs on top of drugs on top of drugs, because that just yields, people ending up on 15, 20 drugs, and that's not a good thing. Okay, so I don't want him to suddenly start just taking, antihistamines or anti-itching creams or topical steroids or anything like that. I don't think that's the right thing to do. I think the first thing is make sure it's not one of our medications. So if he stops all of the COC drugs and there is no change in the itching and the rash after a week, then it's very unlikely to be caused by one of our medicines, and I would be happy for him to restart them. However, obviously then, the key is to work out exactly what the cause is. As Kuan alluded to earlier, there can be a range of biological drugs especially, but chemotherapy agents as well, or normal bog standard drugs that can also cause, generally any drug pretty much can cause skin rashes and allergies. It's just useful to talk about that and go through that sequentially with a healthcare provider to make sure that you're sort of looking at things systematically. And it's sometimes a case of trial and error to find out what the cause is and then act on it. Sometimes actually, especially if it's in the foot and the legs, it needs a proper clinical examination to see whether there are any other features. Is there any swelling in the legs? Is there any pain? Is there a sign of any changes in the actual structure of the legs or the tendons, etc. And so I would advise going to see his primary care doctor as well, just to get that looked at. And obviously, if the rash gets worse or he develops any pain or any other symptoms that are worrying, he should go and get a checkup straight away.
Thanks,
and
Pat.
in terms of the second bit, how long can patients be on the COC protocol? Sorry, I've just seen that bit. We have very sort of particularly chosen drugs that we know are very safe to be taken by patients long term. So, both metformin and atorvastatin are generally taken lifelong in patients that need them. So metformin is taken first line by patients with type 2 diabetes, who will generally remain on it lifelong in many cases. And as the age of diabetes diagnosis goes down and down, people can be on them from the age of 40 till the age of 80 without any overt side effects. And it's the same with statins, actually. So these are two drugs that are very commonly taken long term. The other two drugs, the two antimicrobials. So with doxycycline, there is a precedent for taking it long term, not just as a drug to stop rashes and things like that associated with biologic drugs, but also we do sometimes see patients who have had splenectomies, they've had their spleens removed for one reason or another, who take a low dose of doxycycline lifelong, or people who are at high risk of developing chest or urine infections who take a low dose of doxycycline as a preventative, a prophylaxis we call it, long term. So we think that probably is reasonable as well. Mebendazole is the one that in normal clinical practice we wouldn't normally use long term. And most people that take mebendazole as a sort of anti-parasitic drug will normally be taking it for days or a week at the most. But actually we have developed an awful lot of experience with patients taking mebendazole long term, especially with our brain cancer patients who take a slightly higher frequency of mebendazole long term. We have people who are 5, 6, 7 years in some cases down the line who have taken mebendazole consistently for that period of time, and it doesn't seem to have any long-term issues. So technically, we think patients can be on the COC protocol very long-term, although obviously we are monitoring the safety of that and hope to publish some data on that in the near future. I hope that answers your question.
Thanks, Pat. And there's a question from Lise about Ewing sarcoma. So I'll start that off, and then doctors, please comment afterwards. We have seen patients with that disease. I think in Lisa's case, it's a soft tissue Ewing's. I think, as I mentioned earlier, there's just a little bit less data on sarcomas in general compared to more common cancers. But we have got research on the medicines used at the clinic in the context of various different subtypes of sarcoma, including Ewing's. But there's data in osteosarcomas and different soft tissue sarcomas, and a number of patients that we see at the clinic. We haven't yet been able to report on this cohort as a group, but we are seeing some encouraging responses in individual patients, and certainly the treatment is being well tolerated. So it's something that I think we would encourage a patient to look at, to send us baseline medical information in the normal way, so the doctors can assess it and then give you a personal answer really on whether they feel there's a benefit in that particular patient and their the status of their disease in trying the protocol. Is there anything that you would add, doctors, to that?
No, just to kind of reiterate what you're saying. I think, yeah, we easily seen over 60 sarcomas in general, all different types, and of course, even with the kind of histology specific cancers, geographically or anatomically, they are different, but a lot of the behaviors are the same. So that we do have some experience with this. I think I read somewhere, at least, that you were receiving chemotherapy or radiotherapy, and there's a question about whether the protocol would be suitable for you after that point. And yes, of course, that would need to be looked at in terms of your current blood tests, etc., to see what your clinical state is at that point. But if that is all stable, then absolutely, of course, you would be eligible to start on the protocol at that point. We have had people who have been on the protocol while they've been receiving their standard of care chemotherapy or radiotherapy. So that's also a possibility or an option. Again, obviously, that depends on your primary treating team locally as to how that's managed. But certainly, I think your particular case would be a good candidate for the protocol.
Thanks, Santava. I think we've come to the end of the questions. If there's anything that we've missed, we will export this list and reply separately on that. Jacob, is there anything that you'd like to ask, or anything you think we haven't covered that you want to get to?
I think we did cover quite a bit, and you see, we went through almost all the questions, so nothing to complain about really on that part. That was great. Thank you guys for showing up here with a full team. That's very, very awesome. Thanks.
Great. Yeah, well, thanks to all the doctors, and thank you to everyone who's attended. I hope that was interesting for you. What I'll do is I'll send some follow-up information to Jacob, and he can share that to his Facebook group. I'll try and include some mug shots of everybody to make up for the video not working, so you can see who you've been talking to.
Or maybe you shouldn't.
Or maybe I shouldn't, exactly. Yeah.
Yeah, but thank you very much, everyone.
Yeah,
obviously, it's clear that there's been a lot of individual research that's gone into this and looking things up, and that's really important, I think.
Yeah, thank you very much, and I wish you all the very best with all of your journeys.
Yeah, and please stay in touch and let us know if there's anything we can do to help, of course.
Or maybe did we cover this? What, from a Danish perspective, if you a new patient, what do they need to do to get a consultation with you guys? What's the most essential? Yeah,
I'll run through that as a recap, and I can also send that through to you, Jacob, so you can post in the group. So as with UK patients, we would need to receive baseline medical information to make an assessment about the patient's suitability, and that's typically 3-4 key pieces of information. So we'd need the original reports in Danish, and then an English translation of a recent letter that just summarizes the diagnosis of the patient and any treatment that's been received to date or is being proposed for the future. They ideally, in addition to that, that's an essential piece. In addition to that, we'd also like, if possible, to receive a translation of and the original of the latest scan report. Then, in addition to that, we would need blood results from within the last 4 to 6 weeks to include the full blood count, the liver function, and the kidney function. And those are universal, so no need to translate that. And then just a list of current medication that the patient is taking. And those can then just be sent to our main email address. And it will be assessed by one of the doctors here or one of our nurses. And then if everything is fine, we will just then contact you to book in a video consultation. And that's typically a 45, 50-minute discussion with the doctor, running through the history, running through questions the patient will have on the treatment, the individual medicines. And at the end of that, we would need to send you a consent form, send the patient a consent form to sign for treatment to go ahead. And then, as I mentioned earlier, we can then send a private prescription, which can be used in a pharmacy in Denmark. And if the pharmacy, and in many cases they may want this, they'd like the prescription faxed directly to them, we can do that as well. And then the process is, again, as per UK patients, you have a line into the clinic for any follow-up questions there may be once treatment has commenced. We'd like her to review another set of bloods 4 to 6 weeks after treatment has started. And then we would review a formal review appointment, again by video, can be by phone, but ideally via video at 3 months, where we would look at the situation at that point, how things are going, review the latest blood test results, any other diagnostic interval diagnostics, further scans or other tests, and make a decision on ongoing treatments and whether it's appropriate to change any medicine dosing or any of the scheduling of the drugs. I think that's covered everything there. Doctor, did I miss anything?
No, I don't think so.
Sounds pretty good. Yeah. I think that's
And I'll send you a summary of that as well, Jacob, so you can add that in for patients.
Cool. Okay, fantastic.
All right. Well, thank you again, everybody, for attending. And if anybody here who's been on the webinar has any additional questions, please send an email to info@careoncologyclinic.com for my attention. And one of us will come back to you privately on that.
Thank you very much.
Thanks, guys.
Thanks, everyone. Take care.
Have a good evening.
Thank you.
Very best. And thanks, Jacob.
Take care.